From the RSNA, I'm Dr. Yana Hanidze, and this is the Radiology Imaging Cancer Podcast. May is Brain Tumor Awareness Month, and we are dedicating this episode to brain tumor research and advocacy. I'm thrilled to be speaking today with Dr. Edjah Nduom. Dr. Nduom is Associate Professor in the Department of Neurosurgery at Emory University School of Medicine. He's a neurosurgical oncologist, scientist, and advocate. His prolific career began at Stanford, where he obtained a bachelor's degree in biomedical engineering, subsequently graduating from University of Pennsylvania School of Medicine and completing his neurological surgery residency at Emory, as well as 2 neurosurgical oncology fellowships, one during his training at the NIH and one after residency at the MD Anderson Cancer Center. He has published numerous peer-reviewed manuscripts and has been PI or co-investigator on a large number of federal and foundation grants. He recently opened a first-in-human clinical trial using implanted cytokine microdialysis catheters to discover how systemic checkpoint inhibition affects cytokine expression in the glioblastoma microenvironments, which I thought was very exciting and would love to learn more about. He has been honored with numerous awards, including most recently the American Academy of Neurological Surgery Emerging Investigator Award and the National Minority Quality Forum 40 Under 40 Leaders in Minority Health. He is also an outspoken patient advocate and on the board of directors of the National Brain Tumor Society. Dr. Nduom, Edjah, welcome to the podcast.
Thank you very much for having me. It's fun to be here.
Great to have you. Let's dive right in. You have distinguished yourself as a prolific surgeon scientist providing the highest quality clinical care for countless patients with brain tumors, while also advancing the field of tumor neuroimmunology. Among other research interests, you have published on current and future biomarkers of immunotherapy for treatment of glioblastoma, and are also the lead author on a recent position paper advocating for biopsy in patients with suspected recurrence. Like many of our listeners, who many of us are radiologists or imaging researchers, I'm personally very interested in the development of robust imaging biomarkers for improved diagnosis and treatment response assessment in GBM. And I would love to hear your perspective on what we as radiologists and imaging scientists should be focusing our efforts on in this field.
Yeah, thank you very much for that very perhaps overgenerous introduction and for that question, as this is something I'm actually interested in. I work very closely with the neuroradiologists at the various institutions I've been at, including John Buttman when I was at the National Institutes of Health, and here, there's several fantastic neuroradiologists, including Brent Weinberg, who tends to be our go-to person for our tumor board, et cetera. And I'm always posing, he's great. And I'm always posing this question to them of how we can better figure out what's going on for our patients. So you'll be no stranger to the RANO criteria, the radiographic assessment for neuro-oncology, and then the modified RANO, the iRANO for immunology that purports to give us some sort of roadmap on how to figure out what's happening with patients at any given time and say, okay, if they're getting a given therapy, they're progressing, they're not progressing, they have pseudoprogression, which of course is the response that we may see on imaging in the window after they've had radiation and chemotherapy, where there's a big contrast enhancing lesion and we're all trying to figure out what it is. Everybody's got their favorite way of figuring out, quote unquote, whether a patient is having pseudoprogression or not. And then you throw immune therapy into the mix. There's all sorts of case reports and things in the literature, and it's even more messy, right? You see a contrast enhancing response and you can convince yourself that that's a good contrast enhancing response, and you have patients that are doing well. And so quite honestly, I tend to be a little bit agnostic in this discussion. Where I tend to go on it is, I would love for there to be an imaging biomarker. But before we get there, and this is one of the papers that I just published as a position statement from the Christopher Davidson Forum, which the Christopher Davidson Forum is a meeting held by the Washington University of St. Louis, mostly by the neurosurgical oncologists who run it, good friends down there, Albert Kim, Gavin Dine, and Dr. Luthard. And they have put together this meeting, which is really great. It's really a brainstorming thing. We talk about the various issues in tumor neurosurgery, but also there's neuro-oncologists, there are neuroradiologists, radiation oncologists, and we really want to talk outside the box, think outside the box, try and come up with new ways of approaching things. People share their unpublished data and just the things they're brainstorming on. And the first output from that conference came from a discussion we had about this very issue. How are we figuring out what's happening on clinical trials, and what should we be doing? And one of my soapboxes, I have a couple soapboxes, but one of my soapboxes is I go to meetings and I tell people that we should be taking more tissue on trials. So far, every time I've sat down, and I'll ask you, but every time I sit down with one of the super bright neuroradiology people that I deal with, no matter what advanced imaging they're doing, there's a young guy, David Campson, who's a neuro-oncologist at NIH right now, in the NIH Johns Hopkins Fellowship Program. We've been chatting about this, and he's into PET markers. Yes, okay, PET markers are great. So what's the PET marker that can definitely tell me that this is tumor that's active and this is inflammation? And then they'll wax poetic about a PET marker that can find macrophages, right? So, there are PET markers that track macrophages very well. It's like, oh, that's perfect. So macrophages, a lot of macrophages in pseudoresponse in immune therapy. And they say, well, yes, but there's also a lot of macrophages in glioblastoma.
Yes.
I'm like, well, that's true. So then we're stuck. And then, perfusion. And it's like, okay, yes, perfusion will be great. So sometimes pseudoprogression is cold and true progression is hot. It's like, great, so we'll use perfusion. But then I've taken multiple patients on checkpoint inhibition to surgery who have a hot, highly perfused, contrast enhancing, progressing lesion. It's been more than the 12 weeks that Irano says we can wait to see whether it's progression or not. And I take it out and it's just a ton of CD68 positive macrophages and no replicating tumor cells.
Yeah.
So I think there will be some combination of imaging markers in the future that will obviate this need. But today, with the current state of radiographic imaging that we have, I think that trials need to be designed to have your best guess of what the best imaging marker is going to be for determining progression versus pseudoprogression, plus specified endpoints at which we will again obtain tissue so that we have the ground truth.
Yeah.
And if you have the ground truth more often, plus these advanced imaging modalities, then we're going to be able to eventually say, well, every time we get a biopsy and it's pseudoprogression, these are the things we see. And then we'll be able to go forward and have a perfect radiographic marker. But if we try and just do new imaging techniques without getting the ground truth at the same time, I think we're going to be stuck.
No, I think you make very good points. And, as someone who does research into both new MR-based approaches to GBM imaging as well as PET biomarkers, I have to unfortunately throw my hands up and say, ultimately, we can never be 100% sure, at least with what we currently have clinically validated in clinical practice, which on the PET side is not that much, right? We have a few exciting trials going on around the country. We have amino acids, shameless self-promotion. We have a trial open now for GBM, FLT, F-MISO, dual tracer dynamic PET, so we can image proliferation and hypoxia in GBM simultaneously. We just imaged our first patient. It's very exciting, but I cannot yet tell you how it's going to be helpful to you. I'm hoping that it will be helpful because we will be able to better prognosticate who will respond better to radiation, for example, but we still have a long way to go. And with perfusion, as you mentioned, perfusion can be very useful specifically to distinguish progression from pseudoprogression, and we use it in this way clinically, DCE MRI in particular. But once patient is on immunotherapy, it makes it very challenging to interpret, as you have mentioned. So we'll have to see what happens. So let's switch gears a little bit and talk about mentoring. You have mentored many current and aspiring neurosurgeons and students interested in related disciplines. What advice do you have for medical students and residents who are interested in brain tumor research in particular? And how should they go about finding the right mentor?
Oh, that's a great question. A lot of it depends on where you are. Some students are in places where it's very easy, right? I mean, if a student is at Emory right now, I can hook them up with a researcher in practically any specialty in neurosurgery. And if it's something that we don't have a neurosurgeon scientist specifically studying, but it's neurosurgery related, there are several other researchers across the university that I can connect them with, and they can work in collaboration with one of the neurosurgeons or with that, PhD or, other clinician in another related subspecialty and do some really good work. So there's a student at Emory, you find me or, one of the other, faculty, and we'd be more than happy to connect you with someone to do some research with, even if it's at Georgia Tech. It can be a little bit harder if there isn't a neurosurgery department at your institution. And so what I typically recommend, so there's a few things. One, for some people, probably not for you, Yana, but for some people will seem strange, is I recommend that students have a professional Twitter account. The reason that I recommend that is that one, people, when you get to that point of application and whatever, are going to try and find you in whatever way that they can to get some quick information about you. Young people these days are very private with their social media, and they're right to do it that way. So maybe they don't find you at all. That's fine. Or maybe they find stuff that you posted a long time ago that you forgot about. That's maybe not as fine. But what's ideal is that you create your public persona of the things that you do professionally that you're interested in that they can find right away. And it's almost like a mini CV. So I encourage my mentees to papers they're publishing, the things they're reading, they're interested in, that they engage with that on Twitter. And spending a little bit of time on, say, neurosurgery Twitter, you'll start to see that there are certain neurosurgeon scientists that are doing work that you might be interested in, some of which you might be able to participate remotely. And for the more active people, they're very responsive. You send them a direct message, hey, I'm a medical student, I'm interested in doing research with you. And they'll often find a way to meet with you. I've met several mentees in that way and started to discuss projects. And I don't always have a project for everybody, but I might be able to say, well, I see that you live in such and such a city. Here's somebody nearby or a medical center nearby where I know there's someone that you might be able to do some work with. The other thing that I say that's really important for medical students in that area is one, obviously do the research on the person that you're writing to. Every once in a while, I get an email from somebody, who either one doesn't realize I've moved from the NIH to Emory, even though they're sending an email to my Emory address asking about whether they can do research with me at the NIH, or are writing to me, which my research has been very clearly in tumor immunology and new treatments. And they say, well, they're interested in functional neurosurgery. I'm like, well, that's not actually what I do. So know what the person you're writing to is interested in and how you might be helpful to them. And in addition, know that they might be busy. So don't just send one email and leave it at that. I don't know personally anyone who's offended by receiving a second email, but I have had several students who I missed the first email, but I get the second one, and that's the one that I respond to, or the third. It's okay to be persistent. Don't be annoying. I wouldn't send them like an email, 15 minutes after the first one if you haven't responded. But wait a week, follow up, provide more information if it's something you want to work with.
Totally. I 100% agree with everything you said. Agree with MedTwitter being very helpful. And I myself have actually been very lucky to connect with wonderful mentees through MedTwitter. And I'll give a shout out to two of them because they've worked closely with me. And I cannot by any means take credit, but they both matched into radiology. So Jose Rodriguez, who is actually an IMG from Honduras, who's reached out to me via Twitter direct message and said he's very interested in my work and would love to work with me. We came up with a project that can be done remotely. It's cost effectiveness analysis. So it lends itself really well to remote work. And he's done extremely well, multiple abstracts, writing manuscript right now. And he matched at Penn, which I'm incredibly proud of. And like I said, cannot take the credit. He's done a lot of other prolific work and has a great CV, but Twitter definitely helped us connect. So that was wonderful. And also Jefferson Gwen, who is graduating, so soon to be MD from Northwell, who just matched at Yale Radiology. We also connected via Twitter and have already written a book chapter together, and he's done really, really well. So yeah, MedTwitter is great in that way. And mentoring and supporting budding radiologists is truly one of my favorite things about my job. So this
there
is
you
great.
Go. You heard it here, folks.
So
Twitter's the way to go.
You should definitely all follow Dr. Nduom, Edjah, and we will make sure to link to your Twitter profile in the show notes. So I wanted to talk to you about another topic. You have written a number of impactful papers advocating for increased Black representation in neurological surgery. and have been an outspoken advocate in the fight against systemic racism, sharing your experiences, your personal experiences through publications, as well as on Twitter. Just talked about Twitter in a more lighthearted way, but it can also be very important to shine a light on important, difficult issues of our time, such as racial disparities in healthcare, systemic racism, and as well as the famous Black in the Ivory hashtag that I remember very well, a thread that you posted about your own personal experience. Could you share your perspective on why it is so important for all of us in academic medicine to recognize that taking a stand against systemic racism is very much our lane?
Yeah, thank you for that question. As a Black man in neurosurgery, I know there's not a lot of us, and that kind of gives me a particular spotlight and platform. Early on in my career, to be quite honest, and even to this day, I was talking in the leadership course. They asked us about our fears when we talk about living to our principles and leadership and that sort of thing. And to this day, one of my fears is that by saying something about race, by being a Black man in neurosurgery who's outspoken about race, I could lose the platform that I have to potentially enact change in the field. To this day, every time I'm asked to or decide to speak up about race, it carries with it some professional cost, some potential, I should say, professional cost.
I'm really sorry
and I have to weigh that.
That's the case.
That is the society we live in. We live in a society where certain people will saying systemic racism is a political statement. That systemic racism exists is inherently political. People will say that. I would argue that that's not a political statement. It's a description of the society that we live in and have lived in for a long time. And that's not about any one individual. Saying systemic racism exists is not calling anybody a racist. It's just saying that there are powers that are out there that promote a status quo that prevents the attainment of equity for certain people because of the color of their skin. And that's where the US has been for a very long time. So if that's the case, and I know that has had an effect on me, and it's having an effect on the mentees and the trainees and on the people that look up to me, I guess, I always, I guess, kind of hesitate saying that. It still feels a little bit strange to be the person that people are looking to, as opposed to being the person who's looking up to others for guidance. But nevertheless, I have a responsibility to speak out.
Yes.
And so, again, there was a time that I would not do that, quite honestly, not publicly, privately. In my training program, or if other neurosurgeons wanted to have a discussion about race or racism, I'd have a private discussion with someone that I trusted and knew that I was coming at it from a good place, and I knew that they were already invested in me and my success, and so maybe there's less risk with them. But speaking publicly on something like that was just something that I just felt to be too risky. My field is quite conservative, and if you were to search a given journal, not for race, because there are papers on race and racial disparities, but for racism, you're not going to find it in our journals, our specialty journals, except for maybe in the past year, maybe, because I wrote a paper and a few other people wrote papers in the past year.
Yes.
So, George Floyd happened, I guess, as far as kind of my emergence of kind of being an outspoken voice on this within neurosurgery. There's kind of two phases in it. One, I founded an organization, Physicians for Criminal Justice Reform, in 2015. And I founded that, again, in spite of my fear of speaking out about an issue that I knew was politically charged, but felt it was just so critical in the most important civil rights issue of our time to work on the forces around mass incarceration. And I feel like physicians have a particular role in that. So I've been doing that work for several years. And then after George Floyd, it just so happens we had created a WhatsApp group that contained a large number of Black neurosurgeons. And we felt that we needed to say something. And we put a statement together. And in the wake of that statement, several things followed, including some speaking invitations, webinar series we did for the Congress of Neurological Surgeons, Black Lives in Neurosurgery, which you can find online. It's freely available for anyone to watch. Has some fantastic presenters like Edjah Blackstock, who's phenomenal. Dr. Blackstock, her sister, the other Dr. Blackstock, is also phenomenal. But Edjah is the one that we got for our webinar. as well as Bill McDade from the ACGME, spoke about diversity in graduate medical training and neurosurgery in general, and then several neurosurgeons, mentors of mine, Dr. Harris, Odette Harris, Dr. Isiku, Nelson Isiku, and Will Curry, Dr. Curry, who's up at Boston, and just spoke about their experiences being Black neurosurgeons, and then culminated in this article that we just wrote to want to increase representation in neurosurgery, and then founded a Black Neurosurgeons organization, which is going to be working on all of those things, the American Society of Black Neurosurgeons. And I'll tell you, just closing on that, it's a weird thing to say. I'd rather not be doing this. I would rather be a tumor neurosurgeon who is excellent at taking out brain tumors and talks about my research on immune therapy for brain tumors. That's what I trained to do. But this work is so important that even though I do still believe it carries reputational risk, that I fight past my own fear to do the work. And that's how important I feel that it is. I
understand. And I'm really thankful that you're so outspoken and about this topic on Med Twitter, in published manuscripts, and also here on our podcast, because let's not forget that every time you, given your personal experience and the fact that you are a Black man in America, you speak about this topic, it's also must be traumatizing for you. So it's not the job of Black Americans to do all this work by themselves. It's our job as a society to learn and listen and see what can we do. And I'm also, I have to say, I'm speaking as somebody who is not American at all, and I'm still somehow on a non-immigrant visa. Let's not get into that, it's a nightmare. But I've lived in the US for 10 years, and I think I've spoken about this a bit in a previous podcast. I came to the US with this very naive view of it's the most multicultural and diverse and supportive place in the world. And I have really, it's taken me a long time to fully realize all the systemic racism, the disparities, and a lot of it happened after George Floyd. So that was really a turning point for me as well.
You know, I commend you for speaking out on it and for educating yourself on it. And I think you're 100% right. It's not just on those who feel the weight of the oppression to try and make change. It's on everyone. But you came to this country not that long ago and have already taken it upon yourself to try and enact some change. And there are people who are born here and saw George Floyd and Trayvon Martin and everyone else before them and think that everything's fine. So there's a lot of work left to do. And I'm just glad that people like you are thinking about these things and working on these things, because it's going to take everyone if we're really going to make significant change.
And this brings me actually to my next question, which is, you know, in the last year, a lot of individuals and a lot of societies, medical schools, professional organizations have come out and taken a stand, have made commitments to DEI work, appointed chairs for DEI, and done other commendable things. And while such commitments are an important step, how can we now make sure that they're followed by impactful actions resulting in meaningful change? And I don't know if that might be a difficult question.
No, I think it's a great question. You know, I think the big thing is you have to measure things and you have to have goals. And unfortunately, that's the sort of thing that makes some people uncomfortable. But if you start from the point of, okay, well, when could we say that we have an equitable society? And everybody has, you know, different targets for that. But, you know, I would say that that everyone has the same opportunities, truly has the same opportunities to succeed. And that's reflected in the success of everybody, you know, as far as distribution of desirable jobs and people living in neighborhoods that they feel safe in and comfortable, and that their kids go to great schools and, you know, have great opportunities. And that wealth is freely and distributed by the people that live here. Everybody that lives here has an equal share of the wealth of the country. And that means, you know, that neurosurgery in Atlanta, you know, Georgia is about, I think it's like 30% Black, and Atlanta specifically is like over 50%. And that's not reflected in the people in kind of the best jobs in Atlanta. Neurosurgeons in Atlanta don't have that sort of demographic. So if you would think that everybody had the same opportunities and you believe, which as I do, that everybody has the same capabilities across race, because race as a social construct, it doesn't confer upon it any particular intelligence or other characteristics that would make one more better suited for one job than the other. So if you believe in that premise that the races are equal, then you would expect that in an equitable society that yeah, the spoils of society would be equally distributed. And that's not the case. So if you're looking and you're sitting in a university and you're saying, well, okay, well, we made a statement on equity and diversity, and we believe in equity and diversity, you have to take steps towards that equity. You have to know what equity should look like. You should have a picture in your head of the society that you serve and the people that are served by, particularly in hospitals, the institutions, and many of them are in urban centers, very diverse populations around them, not diverse faculty serving those diverse populations. You got to fix that mismatch, and you have to intentionally make decisions to fix that mismatch. That does not mean, and this is where people often I think get in a huff. It's not in any case, and I've never once in any of the positions that I've ever been in advocated for hiring one person over another who is unqualified for a position. However, it tends to be, if you were to look around, you have applicants for a position, that there are 5 or 6 people that are perfectly qualified for the position. And of those 5 or 6 people, you then are starting to try and pull hairs and, split hairs and trying to decide, well, which one's the best person and which one's the best person. And you create some artificial criteria and you decide, well, this person's the best. At that point, that level, that's where the biases creep in. And it's difficult to tease them out, but they're there. Words like fit, pedigree, we know the people that they worked with, it's like we know them very well. We don't know this person from this institution as well. So we can't guarantee their success. This person is a sure shot. But then again, on the credentials, all 6 or 7 or 8 of the people cleared the clear benchmarks you would have for the job. It's in those scenarios where if we're really going to make some progress, people have to step up and say, but you know what? We have some other goals too in the mission of our organization and serving this community and achieving equity, that since they're all qualified, maybe we'll go with the diverse candidate because that serves a bigger purpose. It's a lot of tough conversations that have to come up. It's promotion and tenure, considering a person's commitment to diversity and equity, that should be its own separate, necessary criterion and not a checkbox. They have to truly demonstrate an understanding and a desire to push that. Those are the sorts of real structural changes that I don't see very frequently. But institutions have all the power and legal rights to do that could actually make change.
I agree. And I think a lot of it will also involve just recruiting more diverse candidates so that there are more in the pool and it's not just the one person out of many who then faces those biases I think mentioned. And
absolutely. I think pipeline efforts are extremely important and they will have a huge impact in the future, but I don't want to give anyone a pass on today. While there will be more trainees and everyone in the future to choose from, if we truly dedicate ourselves to pipeline efforts and school equity and all those things. But today, I'll bet you if you have an opening right now, if you have a job opening right now, or you're looking for a resident or whatever you're looking for, there's a diverse candidate that can do that job. You have to find them.
Absolutely. Thank you very much for that perspective. I finally would like to speak to you about your impactful work on engaging with patient advocates on social media and in other ways, particularly via the BTSM hashtag, Brain Tumor Social Media hashtag on Twitter. Could you tell our listeners a little bit about that work and more generally why you feel it is important for us as physicians and scientists to engage with patients and patient advocacy groups on social media?
Thank you for that. I had some patients who were, really big patient advocates in the brain tumor world, and some friends who are very passionate in the brain tumor world. Autumn McDonald comes to mind, someone who in part helped me become a member of the board of the National Brain Tumor Society. She was a member herself. And in any case, working with advocates really energizes me. It's just like seeing patients in the clinic. It energizes me being able to help people and seeing patient advocates take their issue and being afflicted with something and turn that into a positive and trying to find ways to help others. Any way that I can help that, just on its face, there's a selfish, just a little bit of joy that I get interacting with them and seeing their joy and having these very dynamic people part of my network. On a larger scale, patient advocacy is critically important if we're going to see progress in the various diseases that we're looking at. As an individual neurosurgeon scientist, I can operate on a certain number of patients. I can run a certain number of trials, run a certain number of experiments, and have a sphere of influence that way. And I will accomplish some things doing those things, and I'm very focused on doing that. When I'm a patient advocate, I am talking with the National Brain Tumor Society, who is talking with the National Cancer Institute about where billions of dollars of research should go. What direction should we steer these requests for proposals into? Should we be focusing on early phase trials and collecting tissue like I think? I can provide my opinion on that. Patient advocates can talk about how they want to make sure that community cancer centers have better access to clinical trials so that more patients are enrolled on clinical trials, because currently a very abysmal percentage, particularly in the brain tumor world, of patients are enrolled in clinical trials for diseases that are uniformly fatal. And that's not good enough. We need to give more patients those options to have treatments that we think might be better. So yes, I mean, patient advocacy is rewarding just on an interperson, person-to-person, helping people level, but on a bigger structural, if you want to see big change, it's not about me getting an R1, which I hope to get somewhat soon, but it's about putting billions additional dollars back into play in research and making sure that's a national priority. And I can talk till I'm blue in the face, but it's a patient advocate sharing their story. It's Joe Biden talking about the heartache of losing his son, Beau Biden, that then creates the cancer moonshot.
Absolutely.
Right. So that's patient advocacy right there in a nutshell. So it's a tremendous honor to work with the National Brain Tumor Society and advocates across the Southeastern Brain Tumor Foundation, other groups that are working to push care for patients in a better direction.
Yeah, it's wonderful work that you're doing. And I think our audience, many radiologists, may not be as closely familiar with collaborating with patient advocates, but I think it's very important for us as radiologists and imaging scientists to get out there and get talking to patients, why certain types of imaging are important. I think our colleagues in breast imaging have done this very well with regards to encouraging women to get mammography screening. I think we can really learn from them in other subspecialties in neuroradiology as well. And actually, radiology imaging cancer has made it one of our special topics recently to focus on discussion with patient advocates. We recently published an interview with a patient advocate done by our editor-in-chief, Dr. Gary Luker, that we will link to in the show notes. And in an upcoming podcast episode, Dr. Adeline Butcher, our scientific editor, will be interviewing Dr. Teresa Spencer, a clinical neuropsychologist who works in patient advocacy. Dr. Spencer works with patients with brain cancer and will be speaking about her clinical experiences with these patients.
Fantastic. I'm looking forward to listening.
Thank you. So, Edjah, thank you so much for joining me today. I've learned a lot from our conversation, and it was really wonderful to meet you, at least virtually. And I hope we'll meet in person someday when COVID is behind us. And thank you for taking the time to talk to us today.
Thank you so much for the invitation, which for trainees out there came through social media. So again, one last plug for participating in Med Twitter. But this has been a lot of fun. Thank you so much for inviting me, and keep up the good work.
Thank you. This concludes today's podcast episode for Radiology Imaging Cancer. I hope you enjoyed this conversation with Dr. Edjah Nduom as much as I did. If you are interested in learning more about the topics we discussed, please check out our show notes with links to relevant articles for more information. As always, we would love your feedback, so please reach out via our website or on Twitter. Please subscribe on Apple Podcasts or wherever you get your podcasts and give us a rating to help more people discover our show. I'm Dr. Jana Ivanidze, and this is Radiology Imaging Cancer. See you next month.